Hello my friends, welcome back to my channel Alpha Physio Pelvic Care, all things pelvic health and beyond. I have realized that I actually have not made a video on what to expect during physiotherapy pelvic floor physiotherapy appointment. My very first video is about how pelvic floor physiotherapy can help you, but what actually to expect, I haven't done the video, and you will be surprised how many people are surprised when we talk on the phone. I explain to them what may happen, or when they come to me and I explain to them, they're like, what are you talking about? Will happen? Well, will only if we agree on these things to happen. Therefore, I would like to make you a video, and I hope this will answer some of your questions and ease off some of your worries that you might have whilst having pelvic floor physiotherapy appointment. So if you find this video useful, make sure you share with your friends, you like it, and don't forget to subscribe to my channel. If you have more questions, please feel free to write them in the comments and I will get back to you. I try to explain to people what will happen over the phone so they actually can morally prepare on what's going to happen. Pelvic floor physiotherapy does work also with the whole body, with the pelvis, but it does also work with the inside of the pelvis, of what happens inside. So let's take you through the typical physiotherapy assessment and possibly treatment session now in theory. So let's say I have a client and I will kind of give clarification on male and female a little bit, but for now it's a client, somebody who calls me, they book an appointment and they have complaints, let's say on tight pelvic floor, right? They believe they might have tight pelvic floor, or maybe they have pain on intercourse. They come to me and first of all I do the history, medical history. Medical history is important to me to see what can be possible underlying causes and contributing factors. Through years of my experience, I do ask some questions that might seem completely irrelevant and out of my field. I need to emphasize that just because I ask these questions, I'm not going to treat the problem related to this question. I'm still going to treat the area that my competence lies in, which is pelvic floor physiotherapy. However, I will explain to the person how their current health status might be related to the pelvic floor. The questions that might seemingly not related to my particular field I might be asking, when did you do your blood work? Have you been anemic or are you anemic? What about your vitamin D status? How is your diet? How you prefer to eat? How is your stress level? How is your sleep? Were there any episodes of any traumatic experiences? Then can be also traumatic sexual experiences. Often I might not go straight away with this question, but you can call it a bit of professional intuition. I can see after 1 or 2 sessions that person might have experienced any sexual adverse events. It might not be something like violence, but it might be a negative sexual experiences with their current or past partners that have affected how they feel about themselves and have directly or indirectly affected the pelvic floor issues. So these questions might come later. I will ask you about your thyroid health. I said habit, sleeping habit. I will ask you about your work, about your exercises. These are common questions. I need to see how much stress or maybe not enough stress your pelvic floor gets. I will ask you any kind of related diseases, and I will ask you also the rest of your musculoskeletal health, because I am initially musculoskeletal pelvic floor physiotherapist, and I absolutely do believe, and I see this in my practice, that pelvic floor does function together with the rest of your body. It doesn't function there by itself. So yes, your foot pain might be relevant. Yes, your broken leg might be relevant to your pelvic pain. Your breathing pattern might be relevant. Your dental work that done has affected your jaw and neck might be relevant to your pelvic floor. So many things might be relevant. I might not overwhelm you with all these questions right at once because I do have a standard form I fill in, but later on these questions might come up. So if I do ask you something weird, it's not because I'm nosy, all right? It's because this information creates a piece for me what might be happening to you. After we had our chat, of course, I will be listening to the history you might provide. I will do the full body assessment. I will have at your posture. I'll have a look how you move. Is there major symmetries, minor asymmetries, and so on. I will have a look how you breathe, how you stand, abdominal wall, your hips position, and a generally whole body assessment. Usually it's done in underwear without any shoes. We move on the pelvic floor, and I will talk about the particularly pelvic floor in a bit. Before I get to the pelvic floor, I do check abdominals. For both male and female, I do check abdominal wall. I see if there's any tension. I see your breathing patterns. I see how is your rib cage moving. I might put my hands on your rib cage, ask you to breathe in different position, in standing, in laying down. I might palpate any scars you might have. It can be cesarean section scar. It can be even small laparoscopic scars. It can be any scar on your abdominal wall from anything. Then, after we checked the abdominals, I will also check for diastasis recti, if it's relevant for the history, the separation of abdominal muscle. That is a theme for yet another separate videos. I will move on to the pelvic floor assessment. Now, let me tell you first how it's like done by the book, let's say, usually, and what are the different options that might be there. Let's start by the book bit, all right? So pelvic floor assessment is done internally, usually through vagina in females and through rectum in males. If it's relevant to the symptoms of a female, the assessment is done also intrarectally. And for the assessment, I use single-use gloves and a very plain medical grade water-based gel. This is an empty box that I have here. I brought from work. I have the same full. So I usually put plenty of lubricant, but before I go in, I usually check the area from the outside. I will ask patient to cough, to sneeze, to bear down, and generally have visual assessment of what things look like. Is there any scars? Is there any injuries? Any skin condition? Are there any organs I can see outside? Bladder, uterus. One thing I would like to mention, the assessment usually is done on the back for females. Usually on the side for males, it's more comfortable position. It can be done on the back for males, again, depending on the case and relevant. I know that some people do assess males on their front, so they're laying on the belly. Personally, I don't like this position. It reduces your sense of control and might feel a little bit intrusive because you actually don't see what's happening and you're face down and you kind of cannot communicate sometimes properly. So yeah, this is not a position of my preference. I can get people up and standing, and I usually do, especially if we talk about the prolapse. You get one picture when somebody is laying down, gravity neutral, things are moved back. You get a completely different picture if somebody is up in their legs, and sometimes you just can see the organ prolapsing. You don't even have to like open the labia, right? You can see, we're talking about females, you see, or you just open the labia and you see it again. Whilst when they're laying down on the back, you can't see anything. And this is how they have gone probably to several healthcare professionals, and they say, well, you have a little bit of vaginal wall laxity, but no, you don't have prolapse, because they have been assessed flat on their back. Put plenty of lubricants, and then I slowly enter the vagina. And here, I would like to emphasize, it's not like my aim definitely is not to hurt you. My aim is definitely not to make it as intrusive as possible. My aim is to make it as little unpleasant as possible. Some people will be absolutely fine, no issues, they will feel a little bit of pressure. I'm looking inside the vaginal canal for the muscles. I might go a little bit outside, palpate for any scars again, if relevant, palpate for the tone of the muscles. I might go a little bit deeper in the back part of the muscles, especially if there is a complaint of any pain. We will see if we can find that pain. I might go for a coccyx, again, if it's relevant, because palpating coccyx through vagina, not the most pleasant experience, but if it's relevant and this is something that might be done, needs to be done, yes, we will do it. And then I will ask to do some breathing. I will ask to do some pelvic floor contraction relaxation, see how much movement and relaxation is there. I will ask to bear down, to sneeze, to cough, and we do some normal contractions, we do some fast contractions and so on. So different types of contractions depending what is the indication. I will write down the results later on. I usually finish my assessment and I just remove my finger. I try to do everything in one go, not to insert, reinsert, insert, reinsert. Sometimes we did something, we did the internal assessment, maybe we did some exercises, and then we need to recheck something again. Of course, it's a new pair of gloves, a new dollop of gel and so on, and we start from the beginning. The same might happen with the rectal assessment, because naturally rectum is the area that is tighter. I'll go very easy. If it's necessary to do it with my small finger, I can do that because index finger is bigger, smaller. Sometimes the assessment will not be deep at all. Sometimes I might just stay, let me grab my pelvic floor. I might just stay at the outside here. Okay, or just at the outside of rectum without going in. And this is where we're going to the options. Ultimately, the patient is the one who decides what they want to have done, needs to be done or no. I cannot and I do not want to force any type of assessment that will make somebody feel uncomfortable, in pain, and make them do something that they don't really want to do. It happens to me that a client comes and we do only like external work. They don't even get undressed. We just do things around the belly, around the gluteal area, and that's it. So we build a bit by bit that trust, and maybe by the third time they decide, okay, pelvic floor assessment, something what I want to do. But there is also ways and grades and degrees of pelvic floor assessment. Number one, if you decide to get, let's say, undressed, yeah, I can only look. So, and I have done this before. So I look only from the outside. Usually this happens with people who did have some kind of trauma, or they experience very strong neurological pain. Screwing here. Very strong neurological pain, and things like even light touch triggers them. We're talking about vulvodynia and so on. So they're like, oh my God, I'm scared. If you touch me, I will be in pain for the rest of the day. We're not going to touch. What I want you to do is to spread your legs slightly, and I will just look and I will ask you to do few things. Sometimes they might be comfortable to open up their labia, okay? Or if it's a male, to just lift their kind of gluteal muscles, and I'll just have a look from the outside. Then I will ask them to do same thing, breathing, bearing down, sneezing, coughing, contraction, relaxation. You can see a lot of movement from the outside happening. Or if it's tight pelvic floor or really rigid pelvic floor, no movement happening. You can do a lot of assessment just by looking. All right, so visual external assessment in an undressed state can happen. Then it can be a very shallow penetration. This I've seen again with women with vaginismus. They can just simply not tolerate any deep penetration. So it can be something like staying just at the fourchette, just at the entry of vagina. Okay, and again from there, I can gather plenty of information. It can again me just placing my hand around the anus, asking them to breathe, contract, relax, and so on. Again, gather all this information, and of course I look around what's happened generally in their body. Are they tensing the neck? Are they helping with the glutes? Are they pulling up the belly? And so on. All this observation happens. After we did all of this in whichever form and shape, I usually explain to the patient the findings in the simplest word possible. Sometimes the simplest word are not possible. I just take this and I take my beautiful model here, or I take piece of paper and I just draw. I must make sure the patient understands what they have, and if it's possible, why they. It can be sometimes a guessing game, and I will tell something. Your pain, it's probably caused by neural dysregulation. And neural dysregulation happens because this, and this, or maybe not. But there are also some contributing factors, like, for example, a lengthy sitting, or some kind of stress factors, or probably alcohol, for example, for somebody can be irritating the bladder, interstitial cystitis, and so on. So I explain the findings. After we're done, I exit the room, I let the person get dressed, and then I say, I'll be back in 5 minutes, and we talk. So we discuss, and then from there on, we progress to the treatment. It can be some exercises, it can be some self-relief techniques, so it can be anything. At least few things I will definitely give you to take away home so you can start doing them. Or it can be some advice in relation to your lifestyle and so on. Sometimes the things I explain to people, they might have thought about it, they might have known it, and sometimes it comes as utterly shock to them. So you really need to give space to the person to digest. And if I see that, wow, they really didn't expect that, or it was really shocking for them to have this kind of diagnosis, and I can see that they're upset, you know, we try to talk through it, and we try to talk what is the long-term implications, short-term implications, how it's possibly to live with it, how people live with it, you know, healthy lives and fulfilling lives. And then I will give them just one thing to take away, not to overload them already with the information. And then depending on the case, we might see them again once a week, once every 2 weeks. Rarely I might see people twice a week, sometimes right in the beginning, and then we progress accordingly. So I hope, guys, I didn't intimidate you with all of these things, what's gonna happen potentially if you go for pelvic floor assessment. So yeah, it's always, you're the boss. You decide how much of that you want to have. But my job is to make it as, you know, as positive experience as possible for you. In the end of the day, it's a very intimate area. It's a very, very private. So yeah, I try to be as gentle as possible. I hope it answered some of your questions. If you enjoyed this video, drop a like. If you did have pelvic floor physiotherapy, be free to share your experience in the comments, and we will see you guys very, very soon. Take care.